like to now hand over to my co-facilitator today, Yavor Metodioff, who's from Cardiff and Vale NHS Trust, and he's a consultant anaesthetist with special interest in both obstetrics and neurosurgery and extensive experience of post epidural puncture patching. So without further ado, I'll hand over to my colleague.
Thank you, Byrne, for this introduction. And I would like to first say how honored I was to be invited to take part and facilitate this webinar on patching for CSF leaks. It is my great pleasure to introduce the speaker of this webinar, Dr. Ayman Qureshi, who is a consultant diagnostic and interventional neuroradiologist at the National Hospital for Neurology and Neurosurgery at Queen Square, London. He trained in neuroradiology in the Pan-London subspecialty program, and in addition, he did a further year at the University of Toronto, Toronto Western Hospital. I would like to go straight to Dr. Qureshi and sit back and enjoy the talk.
Okay, thank you for that introduction, Yavor, and thank you all for having me to present on this topic. So we'll be going over the just general use of patching, whether that's blood or fibrin patching in the management of intracranial hypotension. So we'll get started here. So we can break down intracranial hypotension into two broad areas. So if we start with spontaneous intracranial hypotension, this is really a neurological disorder that's caused by a non-iatrogenic leakage of CSF. So this is something that just forms by itself. There's been no intervention, there's been no surgery, there's been no lumbar puncture, etc. It's just something that's developed on its own. And there are different pathologies, and these were really well described from this paper that came out of one of my alma maters, from Richard Farb and his team in Toronto. And he described 4 different types of leak. So the first is what we call a type 1 leak, and this is a little diagram that sort of shows us that. If I just bring this laser pointer on. If we imagine that if you can see the spine here, this is a side view of the spine, that's a vertebral body, and that's the intervertebral disc. Now, as the spine wears and tears, sometimes you can get some bulging of the disc, you can get some little hypertrophy or sort of enlargement or prominence of the bones that happens when there's a bit of wear and tear, and these are called osteophytes. And when those get particularly spiky and pointy, they can cause a tear in this structure here. This is called the dura, the dura being the membrane that surrounds the brain and the spinal cord and the nerve roots lower down. And it is also the structure that contains the CSF. It's sort of the bag, if you will, that will surround the CSF. So the CSF normally sits within that dura, but if you get a breach in the dura, then the CSF leaks out. And if it continues to leak, then you get intracranial hypotension and the symptoms that we'll go over. So in a type 1 leak, that breach in the dura, that break in the dura, is towards the front over here. So it's what we call a ventral leak, and that's a type 1 leak. A type 2 leak is where the breach or the hole in the dura isn't in the midline. Here right now we're looking at what we call a transfer section through the spine. So instead of the leak being here, as it is instead of a type 1, we actually get it here, a little bit more further out, where the nerves or the nerve roots exit the spine at an area called the foramen. So when you get the leak over here, the fluid can run into the spine. It doesn't leak out that way, it goes into the spine. So you still get fluid. When we do our MRI scans, we can see fluid within the spine, something called a spinal longitudinal epidural collection, the term SLEC that you might hear when looking at MRI scans. And when you look at those scans, we refer to those as MRI spine positive scans. And then you get a different kind of lesion called a CSF venous fistula. Now, these weren't described very long ago. These were first described around 2014, but it's quite an interesting lesion in that the leak happens somewhere out here at this location, but instead of leaking into the fluid or into the tissues rather, it leaks directly into a vein. And that's what creates a fistula. So you get this fluid going directly into the vein, and the vein just carries that fluid away. And because of that drawing effect and that constant leak, you end up with intracranial hypotension. They can be quite challenging to diagnose. And then finally, there is a type 4 leak, which is where, quite similar to this leak over here, the leak happens far out here near the root sleeve, and there is leakage of fluid out, but not into the spine, into the tissues adjacent to the spine. So it's sort of going out into this area here, that area there, instead of coming back to the spine. So that these type 3 and type 4 leaks will be spine negative. When we do an MRI spine and we look at it, we won't see fluid in the epidural space, but we rely on other findings such as the brain MRI findings and the patient symptomatology to tell us that this is probably intracranial hypotension, and we need to start thinking about how to investigate these. We go to the next one. Now we contrast that with iatrogenic causes, and these can be due to a lumbar puncture, dural puncture. It could happen after an operation. Anything that opens or sort of compromises the dura allows CSF to come out, and these are sometimes called post-dural puncture headaches or spinal headaches. Now, you've probably been over this from the previous webinars, but we'll go over it again. Typically, intracranial hypotension is characterized by an orthostatic headache, and that means that when you're lying down, no symptoms, but then after getting up, the headache begins, and that's typically over the occipital region or towards the back of the head and the upper neck. Now that's the most common symptom in sort of over 95% of cases, but some patients don't actually have that, and they can have other symptoms such as nausea and vomiting, neck pain, as I've mentioned, interscapular pain, so that sort of pain in between the shoulder blades, hearing disturbances, tinnitus, dizziness, and in rare circumstances, even cognitive symptoms. So sort of the brain's not able to function well, and there's sort of a reduction in sort of thinking function. In the international sort of headache classification, the intracranial hypotension is confirmed when there's a CSF pressure of less than 6 centimeters of H2O. That obviously requires an invasive procedure to be able to tell you that the CSF is low, and it's not required for diagnosis. You don't require to perform a lumbar puncture or some form of pressure monitoring to confirm a CSF pressure of less than 6 to say that there is symptomatic intracranial hypotension or intracranial hypertension. Another thing is only a third of patients actually meet these criteria, and up to 20% of patients will actually have CSF pressures that are on the higher side. So we can't be overly reliant on this figure. So what are the theories as to why CSF leaks cause headaches? We don't really know, but we suspect that one of the features is a traction on the cerebral meninges. So as a patient gets up, the pressure of the fluid is low, so things within the brain begin to sag and pull down. And as that stretches the meninges, that causes pain when the patient's in the upright position. There's also the factor around cerebral blood flow. So if you think of the skull as an enclosed space, it contains 3 things. It contains the brain tissue, it contains CSF fluid, and it contains blood. Those 3 things are what we have within this fixed structure, which is the skull. And this is something called the Monroe-Kelly doctrine that you may hear about. Now, if one of those things gets bigger, then something has to give. The other 2 have to become a little bit less, and vice versa. So if you're losing fluid, then the amount of blood will increase to compensate that. And with an increase in blood, you get increased blood flow into the head. And that is another postulated mechanism as to what causes intracranial hypotension and the symptoms associated with it. Now, as far as invasive or interventional procedures go, epidural blood patches are the first line treatment of symptomatic intracranial hypertension and CSF leaks. Now, in most instances, these utilize autologous blood, that is the patient's own blood, which is normally acquired from the arm or any real sort of venous access you can get. That has the advantage that it's the patient's own blood, so they're not going to react to it when it's injected back into the body. An alternative is a dural sealant called Fibrin or Fibrin glue. And this is something that's sort of created in a lab. It's we'll talk a little bit about what Fibrin is and what the mixture contains and how it works. Most of these blood patches are non-targeted, so we don't, it's the first thing that we tend to do for patients with symptomatic intracranial hypertension. We don't know exactly where the leak is, so we do what we call a non-targeted blood patch. And this is usually in the lower back, in the lumbar region. But when we do know where the leak is, or we've got a good idea as to where the leak is, then we can sort of target the focal point of the leak and do what we call a targeted blood patch. So here's what the procedure involves. Again, this is just a little diagram showing you what the spine looks like off from the side. So these are the bones, these are the intervertebral discs. If we think of this little pink area here as the dura, and inside that dura, you've got the CSF over here. Now, if we just look outside of that pink sleeve, outside of the dura, you get the epidural space. And as you can see here, it's actually quite a small space. It's not a very big space. But this essentially wraps around the dura all the way from the bottom of the spine all to the top and intracranially as well. So the idea for an epidural blood patch is to get a needle and put it through the skin in between the space and get the tip of the needle into that very small space over there. Okay, we don't want the needle going into the dura because A, that can cause, another hole in the dura and potentially another leak. And we certainly don't want to be injecting blood into that space, although rarely that can happen. We want the blood to go into this epidural space. So it can be performed with or without image guidance. My colleague Yavor would probably do this without image guidance. He's very experienced in getting epidural access for anesthesia. When I do these with image guidance. It's certainly preferred. Imaging is definitely preferred if you're doing a targeted injection, because you kind of want to put the needle where you think the leak is or where the leak is. And for any injections that are above the lumbar spine, down here in the lumbar spine, you don't have spinal cord. You've got the nerve roots that go down to the leg. So, if your needle was to go through the dura, then the chances of you hitting a nerve root are quite low. But if you went higher up to the thoracic region or even the cervical region, you've got sort of less room for error, because if a needle could theoretically cause spinal cord injury, and that would be very dangerous. So image guidance is quite useful in those scenarios. And as I said, everything is done in a sterile fashion. Blood is taken from the patient, usually from the arm. Very rarely, if we're not able to get access to the vessels, we sometimes go from the groin to get it from a bigger vein. Now, how does it work? So there are two main ways in which we think that a blood patch improves the symptoms or works in symptomatic intracranial hypotension. So the first way is by increasing the volume of the epidural space and transmitting that pressure intradurally. So if we think of this as being the dura, so the dura surrounding the brain and surrounding the spine, and we get, not really sure if this is projecting and if it shows my needle, but I'll move that out of the way. But if we get a needle into the epidural space here, and we inject blood, and that blood transfers and sort of goes up and down the spine and compresses the dura, because it's in the epidural space, it's going to compress the dura around it into a narrow space. It's a bit like a balloon, squeezing a balloon on one end. What happens to the other end? It balloons out on the other end. And so that pressure is transmitted intracranially. And that then pushes the patient from a lower pressure state into a slightly higher pressure state. And, up to half of patients can actually go from experiencing low pressure to high pressure type headaches. But that's one way in which the low pressure is overcome, and patients most often feel almost immediate benefit after an epidural blood patch. So that's one way. The other way is by actually sealing the hole. So the blood clot creates a seal that stops the CSF from leaking out. Now, CSF has been found to have a pro-coagulant effect. That means it promotes clotting of the blood when the blood interacts with it. So as the CSF goes around the dura, when it gets to the area where the hole is, it forms a little plug and eventually a mesh of fibrous tissue, some of which includes fibrin, to seal up the hole. And that's been found in animal studies. So here's an example of a patient. So this is a 62-year-old with orthostatic headaches. These are some MRI scans. You may have been familiar with some of these imaging findings from previous webinars, but this is a face-on, what we call a coronal section of the brain, and a specific series called a flare series. And you can see this bright white fluid over the surface of the brain. These are called subdural collections, which are one of the things that we look for in imaging when there is intracranial hypotension. If we look at this structure over here, that's called the superior sagittal sinus, and it looks a little bit distended. It looks a little bit round. They tend to look sort of more triangular, but when they look round like that, that tells us that they're a little bit distended. This is the same sort of projection. So again, face on, but some MRI dye called gadolinium has been administered, and you can see that the surface of the brain, you can see this line of enhancement. This is all enhancing dura. The dura is quite thick because it's engorged because of all of that extra blood that we talked about that's coming in to replace the CSF. It makes the soft tissues more full of blood, and therefore it's quite engorged and quite enhancing. And then when we look at this side view of the brain, the sagittal view of the brain, you can see that there's a little bit of drooping of the brain downwards. And so this patient had a non-targeted blood patch. So this is the view from image, X-ray, or fluoroscopic guidance. So we're looking at the spine from a front-on view. This is the vertebral body. These are what we call the spinous processes, and we go in between that space with our needle, keep it in the midline. And this is after injection of some contrast to see how the contrast is dispersing, just to make sure that we're happy that it is in the epidural space. You can see it over here towards the front and towards the back. So it's sort of, the contrast has wrapped around the dura. We don't see anything within the middle of the spinal canal, which is over here. So that tells us we're in a good position. We're ready to inject the blood. And this patient had that injected, and you can see what their follow-up scan looks like a month later. So no more subdural collections, no more enhancement of the pachymeninges. The superior sagittal sinus looks a little bit smaller, has assumed a little bit more of a triangular shape. And the sag, which wasn't particularly bad to begin with, has maybe slightly improved as well. Here's a different example. So in this case, you can see that there is a bit of sagging of the brain. And if these are probably the more important images just to turn your attention to, this is a patient who has a SLEC, a spinal longitudinal epidural collection. So this is somebody that we would classify as being spine positive. If we look at the sagittal side view projection of the spine, you can see this is the epidural collection. So the fluid in this sequence looks bright. We can see it over here, but you can see some towards the front over there, and see this dark line. That dark line over there that just sort of runs down represents the ventral dura. When we look at a cross-sectional image through here, we can see that there's a ventral collection just there towards the front. So that is a ventral collection. In this example over here, you can see that this patient has developed something called superficial siderosis, which is some chronic blood products over the surface of the brain, which is a long-term complication of these longitudinal epidural collections, which is why even if patients are asymptomatic, we generally tend to advocate for treatment of that because of the risk, the long-term risk of developing superficial siderosis. So in this case, because we knew that there was a ventral collection, they had a myelogram. This is before the myelogram, I'm sorry. You can see a bit of contrast within the theca, and a needle has been put through the foramen towards the front where we think that the side of the hole is, and that's where the injection is given to seal up the hole. Okay, and there are different ways you can get to the epidural space, and this is by the use of a CT-guided targeted or non-targeted treatment. Using CT guidance, you can go into the dorsal or the posterior epidural space over here. You can go into the foraminal space, so off towards the side, and then you can go transforaminal into towards the front of the spine over here. So this way you can sort of get your blood or your fibrin into different areas depending on where you think that the leak is. So what are the side effects of this treatment? Well, one of the side effects is not so much a side effect, it's just sometimes it just doesn't work. And we'll talk a little bit about efficacy in some upcoming slides, but sometimes it just doesn't work. You can have a worsening of symptoms, a worsening of low pressure headache. And when that happens, you think, well, was there a dural puncture during the epidural blood patch? Did that needle go a little bit too far and puncture the dura? Sometimes that can happen. Those tend to be easier to treat because then we know that, we know where the site of the needle was, so we know where to go back in and do a more targeted type of blood patch. You can get back pain, and that can be for basically just the inflammatory response that the blood or the fibrin creates when it's injected into that space. It also compresses on the dura, which means you can get some nerve compression. Blood in particular is, if it sits around for a while in the setting of a systemic infection, can itself get infected. So infection is a risk of these things, albeit rare. Neurologic symptoms such as nerve root compression. So, as we compress the theca, we compress the dura, I should say, the nerves within that dura can get compressed as well, and that can lead to pain and symptoms referred down the legs. Arachnoiditis can happen, which basically means an inflammation or a reaction around those nerves within the dura, and that can happen if blood is injected into the intradural space instead of the epidural space. The blood interacts with the nerve roots and can cause a bit of irritation of that nerve roots. A lot of the time there's no real effect, but it is arachnoiditis does remain a risk if that happens. Around half of patients will experience a rebound high pressure headache. So as we talked about, as we transmit all of that pressure by compressing the dura intracranially, it'll increase the pressure of the intracranial space and cause high pressure headaches. Now that tends to settle, but up to 20% of patients will actually need treatment for the rebound high pressure headache. In some ways, if a patient has a rebound high pressure headache, it kind of tells you that the treatment has actually worked, and we expect the rebound high pressure to come down. But as I said, some patients will require treatment for that high pressure. And then in the case of fibrin glue patching, there can be allergic reactions because of some of the constituents of that material, specifically a structure called a protein, which is sort of a bovine derivative, can cause anaphylactic reactions. So when we're giving fibrin, we will usually preload our patients with a antihistamine just to minimize the chance of that. And finally, extremely rare, but if there's the misfortune of injecting blood or fibrin into an important artery that goes to the spine in that location, then that can cause blockage of that important artery and cause a spinal stroke. But this is exceedingly rare, but it has been described. Okay, so we'll talk a little bit about efficacy. So this is a systematic review and meta-analysis from our group at Queen's Square. And I've got sort of a larger table up here just to show you what the differences are between conservative treatment, because that is another way that you can deal with symptomatic intracranial hypotension is basically do nothing, just advocate for bed rest and hydration and see how things work and see if things get better. But you find that sort of in sort of 75% of the time, up to 80% of the time, it just does not work. And it normally takes at least a few weeks for that to take effect. So conservative management is not a very effective way, and which is why blood patches are sort of done as a first off invasive type procedure. Okay, now the success rates for blood patches roughly fall around about sort of 2/3 of patients will respond. A lot of this depends on how you describe a successful treatment or a response. But that's something we can discuss. There's a subsequent slide that I'll show you a different meta-analysis that did describe that. They found in this analysis that there's no real difference between targeted and non-targeted epidural blood patches. They've got similar rates of efficacy, but what they did find is that patients are more likely to respond, I mean, and significantly so if the amount of blood injected is higher. So generally we advocate for at least, or we aim for at least 20 ml of blood to be injected. If the patient can tolerate more, then we'll inject more. But where the sort of 20 ml has been found in multiple studies to be kind of the golden number. I mean, every little helps. If you can't get to 20, then something will work. I mean, for reference, if you were to inject 14 ml of blood into the epidural space, that will travel 9 spinal segments, so 6 above, 3 below. So that's still quite a good amount of distribution just from 14 ml of blood. So however much you can get in can help. Not everybody can tolerate 20 mLs. So we get in as much as we can, but 20 mLs is normally a good target. This is a separate meta-analysis from this group, and they looked at 500 patients from 6 different studies, and quite similar to the one that we just saw. 60% responded to treatment. Here, a good response was defined as complete symptom resolution within 48 hours of the first blood patch, requiring no further treatment. So they had a definition for what a complete sort of response was, or a good response was. Now, if we look at these different studies, they went about their blood patching in a slightly different way. So move this out the way. So these 2 studies over here, the Yoon and Choi studies, utilized both targeted blood patching and blind blood patching, and what they found is that there was no difference between those. There was no significant difference between them. So again, another study that tells us that targeted and non-targeted blood patches aren't very different in terms of how effective they are. So are there any things that we can see on imaging or technique-wise that will predict a good chance of a response? So if there are patients with a epidural collection or a SLEC that's sort of a small SLEC, so shorter segments, less than 8 segments, those tend to have a better chance of treatment. Midbrain pons angles are things that we look at on MRI. It's one of the MRI features that we look at. And if that angle is greater than 40 degrees, implying sort of a milder sort of imaging feature of SIH, then they tend to respond. A higher volume of blood, we've said we aim for sort of at least 20. And some sagging of the brain. If there's less sagging in the brain, they tend to do better. And a separate study from the group from the Mayo Clinic found that multi-level injections in their series were more beneficial than a single level injection, although that's only one study that's found that. So moving on to fibrin glue patching. What is fibrin? Fibrin is the end product of the clotting pathway. So, when there's an injury or when there's a cut, the blood needs to form a clot. And that clot is basically a combination of blood cells that's bound together by a structure called fibrin. So at the end of that clotting cascade, you get fibrinogen and thrombin, which are sort of clotting factors that will combine to form fibrin. And this is really just like a mesh that binds these things together. It's like a seal. It's a natural seal. This structure over here called a protein is something that prevents the breakdown of fibrin, so that when fibrin is there, the body's natural systems to break down that fibrin don't break it down. Okay. Now, this can be used in the setting of surgery. So after the dura has been opened and then repaired, some fibrin glue can be placed there to help that dura seal. But in sort of our line where we're trying to do fibrin patches, we would inject a small amount of this fibrin glue in an area where we think or we have confirmed the leak is, to create a little seal. And this has been found to be more efficacious than blood patches alone when they were compared. So in this study, they had 70 patients, and all of their patients that received, they divided those into a group of 35 that got blood and a group of 35 that got fibrin. All of the patients that got fibrin sort of symptomatically resolved within 24 hours, whereas the patients that got blood, again, had a similar sort of efficacy at around about 65%, as we saw in those earlier papers. There were lower rates of rescue analgesia for patients getting fibrin, and lower volume injection. We can't inject the kind of volumes that we inject with blood because of the risk of hypersensitivity and anaphylaxis. However, you need a target to inject this. You need to know where you're injecting it. You can't do a blind blood patch with fibrin because small volumes. Right. A brief word on something called 360-degree patching. This is a type of non-targeted patch, and it's used when we don't really know where the site of the leak is, but we think it may be in a certain area. So the idea here is to try and get blood or fibrin in multiple different locations. So instead of injecting just into the posterior space over here, we'll try and get something here, we'll try and get something towards the side, something towards the front at the same level or at different levels, with the idea of just trying to wrap the dura with this sealing product, be it blood or fibrin, to maximize a chance of sealing the hole. So that's what we would do. You utilize all different types, the transforaminal, the foraminal, dorsal epidural access to try and seal the hole. So here's an example of a patient with a post-dural puncture headache. As you can see, they've had a myelogram done to try and look for the site of the leak. Often in post-dural puncture headaches, the chances of finding a leak from a myelogram are extremely, extremely, extremely low. But it does confirm that there is no extradural collection, as we can see over here. So what's done at this point, if the suspected area of the lumbar puncture is at L3, L4, you can see these two needles at that level, one going off to the right, one off to the left. This is a bit of contrast that's been injected just to confirm that where we inject, the fibrin will get a good distribution of epidural distribution of our product. And then a third needle is put posteriorly, and you can see what that distribution is like around the dura. Now, there's no hard data out there to tell us that this is more beneficial than just doing blood patching, but it does provide an option where blood patching has failed at the beginning. It's another option that we can present in the hopes of maybe catching a hole that we couldn't get before. In terms of post-procedure care, we typically get our patients to stay in overnight, so 24 hours of bed rest with 6 hours of strict bed rest, so no leaving the bed. Routine observations to make sure that there's no new sort of neurology, particularly in the lower limbs, like weakness or incontinence. Painkillers, because the procedures can be uncomfortable. We then recommend no lifting, straining, bending, or twisting or stretching in it sort of excessively, at least for the next 6 to 8 weeks, because what we're hoping for is for that patch to hold in position. We don't want anything to move that patch out of place and the leak to start again. And we ask for patients to just try and maintain that bed rest for sort of at least a week. It's not to say that they can't move, but it's just to encourage bed rest for that period. There's a very good slide that you can find on the CSF Leak Association website that sort of summarizes some of the things that we've talked about. They include avoiding anti-inflammatories because some anti-inflammatories can prevent clotting. Avoiding salt and caffeine as well, because those can increase the amount of fluid and therefore increase the amount of pressure. And some of the other things that we had talked about. So I think that marks the end of my presentation. If there are any questions, I would be happy to answer them. I will stop sharing now.
So thank you so much. That was really informative, particularly interesting to hear about the different types of patches and also the success rates, and to give some feel for patients to understand what the procedures are, how it's working and what might be going on afterwards. We've got some questions. We've got some questions from previous, and myself and Yavor will throw them at you one by one. Let me just find, goodness, if I just find some questions, and this is for either of you really. If a patient goes into a vasovagal syncope with possible epileptic symptoms during a blood patch, how would the procedure be performed? I think this is patients asking about if they don't tolerate the blood patch, perhaps if they've got POTS or other complications. Do you see patients that struggle with the blood patching, and how would you manage that, I guess, is what's being asked.
So I haven't seen a seizure from a blood patch, although you do get the odd occasion where patients will experience a sort of vasovagal episode. In my experience, those tend to be quite short-lived, and they're able to tolerate as much as they can. So at that point, we'll sort of stop the injection. We do offer more than one blood patch, and as I said, every little helps. So if it means a second blood patch, we know that blood patch efficacy does slightly increase the more you do it. It may be maximal at its first time, but every subsequent blood patch has a chance of doing a bit more. So we'd probably just bring them back. I don't know if you do anything different, Yavor.
I agree with what you just mentioned. I've never seen an epileptic activity or seizure activity, but I've seen a few vasovagal syncopes or syncopal episodes, a bit of bradycardia. We do it in my institution. I do blood patches in theatre environment where patients are monitored, so we kind of almost see in advance that a vasovagal reaction may happen by slowing the heart rate or blood pressure dropping. Usually they're short-lived, they recover spontaneously. I sometimes just wait it out and continue with the same blood patch if the patient is happy for me to continue, or as you say, we can offer another blood patch on another time.
Okay.
I see in the question there's something about pill anesthesia not strong enough. Well, I assume this is sedation, and whether patients receive sedation for the procedure. In my experience, most patients don't require sedation, but I'm sure that it's a fairly short procedure. It almost never takes longer than about 15-20 minutes altogether. I have never used sedation, and patients have never asked for one, but I'm not sure whether Ayman has different experience.
No. So much like yourselves, we don't give patients sedation. It's all done under local anesthetic. I think that there's also probably there's enough reason not to give sedation, because you need your patients to be responsive. So whenever I'm doing an epidural blood patch, I'm always communicating with the patients. I tell them what to expect: headaches, back pain, limb pain, and I ask them to tell me how bad it is, because you need the patient to be able to tell you that, yeah, look, I can't really take much more blood, so you know when to stop. If in theory you just kept on injecting blood, kept on injected blood, and the patient's not able to tell you that, oh, this is getting pretty bad, then you can actually cause quite severe intracranial hypertension. And that can create all sorts of other problems. So you do need a patient that can give you feedback. And if you over sedate them, that can be, they can't do that.
Thank you. Thank you. So that answers some of the other questions I think we had around patients asking about what would stop you. So how would a patient not tolerate after a certain amount? And you've answered that by sort of saying that they would get physical symptoms that suggested that it was too uncomfortable. But on a related question, someone has asked if a patient can tolerate more than 20 mils, is there a benefit to getting more, and is there a kind of upper limit? What do you feel if you've put your 20 mils in and they're fine, they're not struggling with it? Do you carry on or do you stop at 20?
I personally carry on. I aim for a larger volume. As Ayman said in his presentation, the larger volumes have a larger chance of spreading further, and also covering ventral, the anterior side of the epidural space. So I do carry on. I probably would stop at 40 mLs, which is what the recent guidance recommends, or when symptoms reported by patients occur.
Yeah, exactly the same thing. That's I aim for at least 20, but if they're tolerating more than that, I'll go to 40. In some instances, I might even go a little bit above 40. So I'm really sort of I go by what the patient's telling me.
Okay.
But yeah, much like Yavor, 20 to 40.
So a question related to that was if people were having multi-level blood patches, is there a kind of maximum or a target level that you'd be looking to inject per zone? Would that change?
So for multi-level patches, yes, I think it depends on where you're going. So if you're injecting sort of thoracic, then you have to appreciate that the epidural space in the thoracic area is less than what you have in the lumbar area. So you're not going to get away with 20 mils of blood in the thoracic area. So you want to keep that injection volume low. So we're talking sort of around 5 to 10, definitely less than 10 in that kind of area. And that's for blood. Obviously, if you're injecting fibrin, then you're limited by how much you're going to inject anyway, and the volume's going to be quite low.
Okay, so it's quite dependent on where the levels are, really.
Where the levels are, yeah.
Yeah, I think you dealt with this actually in the body of your talk, but one of our questions related specifically to the sort of success rate. I know you gave some quite specific statistics from different studies. This question just asks for a kind of broad brushstroke success rate from the first patch, but then also from the second patch. I guess what they're saying is the success rate from the first patch is quite high. If that doesn't work, how hopeful are you that the second patch is going to be the treatment, curative for the patient?
Shall I start, Ayman?
Yeah, go for it. Yeah.
From my experience, we have different information for blood patches after iatrogenic leaks, which is commonly seen in obstetrics, where we do epidurals, and we know what caused the leak, and the success rate seems to be slightly higher in those blood patches, and we quote about 60-75% of the first blood patch being successful, and about 18% of patients will have a partial benefit of the first blood patch. I would say the success of a second blood patch will depend on whether the first one produced some relief but not complete, or no relief at all, with more likely the second to help those that had a partial relief with the first one. And some papers quote up to 97% of second blood patch patients will have at least partial, if not a full relief. Maybe Ayman will have information on more of the non-iatrogenic blood patches. However, I think it's quite scarce data there.
Yeah, yeah. So yeah, I mean, I think there'll be data out there that says generally from as I'd shown you, around 2/3 of patients will get a response, and then for anyone that goes on for a second blood patch, there'll be some data that says 1/3 of those patients that come back for their second one will get an additional response. Now you can keep doing blood patches. That, you know, we at Queen Square tend to stop at 2. We will do 2 blood patches before we go on to start doing more sort of myelographic and investigative type studies to try and locate the source of a leak. But yeah, I think it varies from institution to institution. But yes, there is a proportion of patients, and as Yavor said, there's a certain subgroup of patients that will do better from a second blood patch.
So related to the success rate, there's a question that's just come in actually around if the patient has had a symptomatic significant improvement, so they feel back to normal after the blood patch. Would you accept that as a success, or would you normally image to see if any signs of hypotension intracranially had resolved?
Yeah, so over at Queen Square, if there are positive features, so you know, so for example, in the case that I showed in my presentation, she had clear imaging findings, had a blood patch, and then completely resolved symptomatically. But we did do a follow-up, and whilst her brain looked a lot better, as you could see, she actually had a spinal collection, and that spinal collection didn't go away. So here we've got an instance where the patient is completely well, completely asymptomatic, but has a persisting spinal collection. And then we now have to get into those discussions around, well, we know you're well, but we know that having a persisting collection, which infers a persisting leak, even if it's asymptomatic, has long-term sort of problems. In this case, you know, there's a risk of superficial siderosis. So you know, she actually did end up going on to have a myelogram to locate the side of the leak, and then we can have separate conversations about, well, we can offer things for this, but yeah. So yes, we do re-image after if they've had positive findings. That is, we do re-image typically at around 3 months after the procedure.
Okay. So there's a question around the positioning after you've finished the patch, particularly if there's an anterior epidural space. So if perhaps you've got a ventral leak or something, is it likely that it's better for the patient to be prone to lie in a particular position to try and encourage the blood to sort of slide into the right area, or do you normally just lie on their backs as comfortable?
So when we perform non-targeted blood patches, we usually don't know exactly where the leak is, as this is kind of the algorithm is we start with the blood patching, and depending on the result of this, they may go for myelography to identify the site of leak. So I have never, you know, asked patients to lie ventral or kind of prone with face down to encourage blood. We have to remember that blood injected into the epidural space, we're talking about minutes before it either clots or dissipates within the myofascial planes, so between the muscles, and it's probably a very small amount of this blood remains in place in the epidural space. And I feel that positioning prone will add very little, if anything, to pooling blood. The blood is not in free flow in our epidural space after the injection. We know that once we draw blood out, it takes about 5 to 6 minutes, even less, 3 to 6, I would say, in a healthy blood clotting system for the blood to start clotting. In addition, there is CSF in the epidural space, which, as Ayman said, has procoagulant effect. So it will encourage the blood to clot. So lying on your face is probably not going to change where blood goes. I think blood goes where it goes during the injection itself, and after that, it's pretty much a matter of physiology taking over.
Yeah. So yeah, agree with those points. But in addition to that, I think placing prone can actually be detrimental. So we know that by being in a prone position, you increase your intracranial pressure because that compresses your chest and your thorax, and that has, when you compress that, that has the effect of increasing intracranial pressure. So when you've subjected a patient to a procedure that has increased intracranial pressure, and then you exacerbate that more by placing them prone, you could actually be doing something detrimental. So we don't place patients prone. We just ask them to lie supine, and that's it.
Okay, makes sense. That's really helpful. So there was a question around if a leak is identified sort of many years later, so someone who's perhaps been initially diagnosed with migraine or something like this, and then has had a query and there's been a suspected leak, but perhaps the scans have been reviewed. Is there any point at this late stage in offering patching, or are these patients better going straight for sort of myelography to try and pinpoint and then probably a surgical solution?
I think, yeah, go for it, Yago.
My answer will be a bit short because my experience I've not cared after many patients with long-term headaches. I've had a couple of patients, and from my very N number 2, N equals 2, one of the patients had over 10 years headaches, which were diagnosed as different headaches until a diagnosis was made through a myelography, and one blood patch resolved his headache completely, and he was amazed at the result of this one blood patch, which, if I have to be honest, I was skeptical that it will provide full resolution of symptoms. And I think we are very, as a community looking after those patients, we're very behind on knowing what these long-term sufferers, if I may call them that, or patients with headaches for long-term, will react to a blood patch. So in my opinion, it's worth trying before going for a myelography, but maybe Ayman has a better information on those long-term patients.
Yeah, so I mean, at our practice at Queen Square, I think the majority of the patients that we see are actually patients that have had symptoms for a long time, because, you know, intracranial hypotension is often, as we know, is often misdiagnosed as something else. So by the time, you know, this whole question of, is this symptomatic intracranial hypotension raised, it can be years down the line. So that's a lot of the patients that we see have had their symptoms for a long time, and it remains the first thing that we do, blood patching. So absolutely, there is still a role for blood patching.
Okay, that's useful to know. Thank you. There's one final question that I've just seen here, and you dealt with how patients should how they should be managed immediately after the patching, so that they should rest for 6 hours and, you know, strict bed rest, and then take it very easily. And you really helpfully highlighted the infographic that we have on the CSF Leak Association website to guide patients. I think the question that we've had today is more general, long term. So if you've ever had a blood patch, this is a patient that asking specifically about deep tissue massages and sports massage, not in the immediate time after the patch, but maybe just, you know, 3 months later. Should these patients continue to limit how they treat their bodies in some way that they might be still fragile, or is it fixed or not at that point?
I would say I think at some point you just need to sort of carry on with your life. I don't think there's anything to say that a deep tissue massage would have any effect on a blood patch, but I just think as a general rule, after a certain amount of time has elapsed, you should just carry on with your life. And if indeed there is a leak that sort of springs up, or a leak that begins to manifest after that time, then it'll need to be retreated or maybe even further investigated. It'll manifest itself and it will be addressed. But I don't know. I don't know if you have different thoughts, Yavor, but those are mine.
I agree that I don't think patients should take certain parts of their life away. It also depends what the cause of the leak was initially, and where in, if it was a bony spur or, mechanical dural tear. I don't think that any masseur or masseuse will be able to provide such pressure that it will press your dura onto the spur. And I would say that, no. We also advise patients who are, especially patients who are planning to have children after blood patches, that they could utilize any analgesia or pain relief for their labor, including epidurals, and they do work just as well as epidurals with people who have not had blood patches in the past. So we don't advise anything different, and we're talking about procedure literally going where blood patches were done in the past.
Thank you. Yeah, I think there is a balance to be had, because obviously a lot of our sort of community have had that experience of just something breaking that wasn't supposed to break, and then that kind of follow on of, well, maybe I'm kind of made of cheese and might break more easily, and what should I do and not do? And then you've got that balance of the less you do, perhaps the more you're at risk of deconditioning, but then equally, if you do too much, are you putting yourself at risk? So I mean, every person, I guess we have to learn what our bodies can and can't take, and work within that. But it is really reassuring to sort of understand that really, once, if the blood patch has worked, then after a certain period of time, we should just try and get back to normal as much as possible. I'm just looking through, and I don't think there are any more questions that we could address live. There may be a few things that we can follow up on if there's anything that's been missed, or if people feel that we haven't answered their questions afterwards. So yeah, there might be one more. Yes, please, on the question answer. New post. Let me see. I found some more. Okay, sorry. So I've got one question here. Can interventions to seal a CSF leak cause adhesive arachnoiditis? Well, that's a really interesting question. And are there any risk factors for this occurring?
Yes, I think I touched on that in the presentation, that is a risk of epidural blood patching, is that if the needle was to traverse the dura inadvertently, and the blood was injected into the dura, then that can cause an arachnoiditis. I think even in that instance, it is quite rare for that to happen. We see, as I'm sure Yavor does as well, we see spinal surgery all the time where, there will be blood within the intradural space, with no arachnoiditis in the follow-up period, but it remains a risk all the same. So it is possible, albeit rare.
Okay.
And it's I just want to add that sometimes, and there have been described cases where it's the solution to clean the skin, and the sterilizing solution, either injected by mistake or wrong concentrations, higher concentrations of the solution used, they're more likely to cause arachnoiditis if introduced into the epidural space. And in our institution, we don't use solutions over 0.5% of the chlorhexidine. But these are, again, very rare. They're usually associated with error of injection.
Okay. So there's one more question here that relating to solutions, I guess, but more of a radiological question, not so much the blood patching. someone's concerned about the repeated use of gadolinium in patients with normal, good kidney function. Is this something that people should be worried about, or?
No, I know that there's been a lot in the press around the use of gadolinium, and yes, with repeated studies, there is data or studies out there to show that gadolinium can deposit in tissues, including the brain. Now, we don't know what the long-term effects of those are. We don't think that there are any long-term effects, but we know that it is something that we see. So I don't think there's any hard data out there to say that there is a risk from the use of repeated gadolinium injections. It's just something that we're more wary about, given that, that we do see deposition.
Okay. There's
albeit
a few
without
more.
effect.
Yeah, that's reassuring that we should keep looking at the data as it goes on, but be quite reassured at the moment. So there's another question that's come through around anything that could have an anticoagulant effect. So obviously there might be a need to stop an anticoagulant medication before a blood patch. And this person's actually asked about any supplements that could have a anticoagulant effect. The one that was mentioned was a fish oil. Is there any things that patients should be aware of if they're taking supplements or medications that should be stopped or withheld before a blood patch procedure?
I can take this, Simon, if that's okay. So that's a good question, and it's very important. We always ask patients before we do any procedure to their spine about anticoagulants and blood thinners. So I would say fish oil is an interesting one, because a lot of people know that it reduces the stickiness of your blood. However, it's not considered an anticoagulant, and its effect is by kind of reducing the platelet aggregation, which is the cells that cause a clot, and it is reversible. So I would say if you're taking fish oil and you're particularly concerned that this may be a problem, stopping it for about 3 to 5 days is usually enough, because this is around the time where new platelets in the body are produced and the old ones are gone. This is similar for aspirin, kind of, although aspirin can be a blood thinner, and it has a irreversible effect on platelets. So it needs about 7 to 10 days to be stopped before a neurological procedure at high doses. At low doses, like prophylactic doses, we usually are not that concerned, then we would carry on with a blood patch. Any other formal blood thinners like warfarin and similar medications, they need to be stopped on an individual basis, as obviously I'm not providing medical advice. However, you need to let your provider that you're taking those medications, and they will give you a plan of when they need to be stopped, for how long, and when they can be restarted after the blood patch.
Okay, yeah, it's a complex issue, and I guess every patient's case is perhaps a bit different. There's been a few more questions just in the last minute. One lady's asked, are blood patches a permanent fix for spontaneous intracranial hypotension, or do you feel that it's inevitable that a further patch will be required later on? I guess talking about those patients that might be in that cohort that was lucky to have a really good response, the 60%, is that it, or are these likely to recur? Was the patch maybe only a temporary fix?
So I think long-term outcomes of blood patching, sort of with permanent effects. This is one of the reasons we get follow-up scans, is that patients can do really quite well, can feel completely asymptomatic, but we require follow-up to look for more sort of subtle symptoms of SIH and subtle imaging features of SIH. So it really depends on what the follow-up shows. If there's been a fail, and there's been a fail after a second blood patch, we will then continue to doing things like myelography, so sort of more direct investigations. So I wouldn't say that it's inevitable that further patches will be required. It's we just need to bear in mind, I think something to spell out here is the definition of success. And a lot of the studies that we've quoted, the definition of success is a complete resolution of symptoms for, within 48 hours. I think long-term outcomes, I don't really think we've got that data. So we really go by how patients are doing, and we sort of follow them up, be it clinically or radiologically, to see how that goes.
Okay, and that, I think, our final question, I think you've just actually touched on that in that response that you just gave. Someone's asked how much time should pass after a patch to decide whether or not it was a success. And I think they're looking there at symptoms, but also you've already said about how long you'd wait to do the scan. So is it 48 hours or immediate or a week or?
Yeah, so typically patients will get followed up, but in our institute, at least in 2 to 4 weeks, there'll just be a more of a clinical follow-up. The imaging follow-up will be at 3 months, but I think it might vary from place to place. Yavo?
It's very similar with us. We do follow them up in 48 hours over the phone to kind of basically assess clinical improvement or not, and to ensure any red flag symptoms are not present. And then a second clinical follow-up is about 2 or 3 weeks after the procedure, and in about 3 to 6 months, as similar to Ayman's institution, we do potentially scanning and a neurological appointment as well with neurologist.
And is it your experience clinically that if patients are going to respond, that the majority will respond almost immediately and feel much better, sort of almost directly after the procedure, or take maybe a day or two?
Some patients do have immediate resolution of symptoms. However, in the next couple of days, they either develop a high pressure headache, or their low pressure headache comes back, but in a less intense manner. And then I've noticed in my experience in the first 2 weeks, there is usually they report good and bad days, but with the usual trend towards reduced symptoms when there's no complete resolution of symptoms. Ayman maybe will have more.
Yeah, no, I echo what you've just said. I think the important thing is if you're having a blood patch and you don't feel immediate relief, that doesn't mean that it's not successful. I think that's probably an important take home here, is that if there is a relief of symptoms on table or very shortly after, that's all very reassuring. But if there isn't, that doesn't mean that the treatment has failed. Sometimes it just needs a bit of time.
Yeah. Okay. And I guess that immediate post-procedure, window can be complicated, like you say, by maybe the initial volume effect, the lying flat, then maybe, like you say, worsening of symptoms that could be confused by high pressure. So you do need that period of things to settle down. So I think we've now reached the end of our questions that have come through live, and also the ones that we had in advance. So that just leaves me to thank you both for giving up your Saturday afternoon to join us. It's been really, really helpful and really informative. And just to remind our participants that we will be putting this on our website and on YouTube. And so anyone that didn't catch it all can come back to us later, or if you feel that there's other queries, then we can always address those at a later stage if we can. So thank you so much to both Ayman and Yavor. It's been a pleasure in hosting you both. Thank you so much, and good afternoon.